Thank you very much for that kind introduction. I'm Lakshmi Nagarajan. I'm from the Perth Children's Hospital, and I can recognize some or many of you here. Thank you to listen, and thank you to Epilepsy WA for inviting me. I'm going to talk about epilepsy and genes. As we know, it is one of the most common serious brain conditions, and it affects about 70 million people across the world. The genetic architecture of epilepsy is quite complex, and often it has multiple risk factors and a strong genetic predisposition. And the epilepsy networks in the brain disrupt other networks, and that's why it's associated with other comorbidities, like sometimes problems with mood or alteration of mood, of cognition, of behavior. And we now learn that not only these comorbidities that we are well aware of, but there's also a high incidence of arthritis, of gastrointestinal problems, of diabetes associated with epilepsy in the long term. Now, when we look at genes in epilepsy, single genes causing epilepsy do occur, but they're not common. And overall, maybe up to 5 to 10% of people with epilepsy have single gene disorders. Most of the time, it's complex, more complex than that. And the gene mutations that occur, the single gene ones, can be in an ion channel, for example, that which affects sodium moving into the cell or out of the cell, or potassium, or calcium. But there are also other things. It could be the neurotransmitters, the receptors for the neurotransmitters, the substances that take something into the cell, or substances that help you get rid of something. So there are a whole lot of genes even within these single gene disorders, or a whole lot of causative mechanisms even within these single gene disorders. And we know anti-seizure medications suppress seizures in about 2/3 of people with epilepsy, children, adults. And pharmacogenomics, which is looking at the pharmacological side of epilepsy associated with genes, may help us select the right drug, may help select the right dosage, because some of us metabolize drugs faster or slower if we have certain genes. It may help avoid certain drugs. If you have a certain gene mutation, then it's better not to go on some drugs. And they also open up pathways where there's a lot of research being done, so that perhaps we will have mechanisms or medications that will prevent epilepsy from occurring, or even cure epilepsy from happening. And genes are very important in every aspect of our life, as we all know. But they may also influence in epilepsy. They may influence the outcomes from epilepsy surgery. And we're learning more and more about that as well. Now, if you look at this classification, I think most of you have seen it in many talks, and you'll have probably looked at it yourself. The current classification that we use all over the world, which has 3 streams. The middle stream is looking at the epilepsy as such. So seizures, epilepsy types, epilepsy syndromes. But on your left is the comorbidities, and on the right is the etiology. So every time, ideally, we should be looking, every time you meet a health professional, or even for yourself, you should be thinking, where are we in these 3 parallel streams? Because etiology can be combinations of all those listed there, and genetic comes up high when you think of epilepsy and the cause of epilepsy. We'll talk a little bit more about that. Now, this is the classification of seizures in neonates. And I think neonates help us understand what happens to us as adults quite a bit, and what happens to the brain pathways at the beginning, and what happens over time. And that is an area of where we are particularly interested. So we've done a bit of work on that area. And this is when you look at the classification of epilepsies in neonates, the etiology, the hypoxic ischemic etiology becomes the most common cause of seizures in the neonates. But genetic and metabolic causes are also there. And if you look at all babies who present with seizures in the first few weeks of life, about 10 to 15% will be because of genetic or metabolic causes directly. And then it might influence seizures because of any of the other causes, the genes. And so this is an era of lots of discovery, lots of gene discoveries in epilepsy. It's helped us classify epilepsies better. It has highlighted the complex relationship and increases our knowledge of, you can identify a gene variant that is pathogenic. We now try not to use the word mutated gene. We try and call it a pathogenic variant. And so if you have a pathogenic variant, it may make that particular function that the gene usually does more or less. And the same, and the medications you use depends on what it does as well. So that's an area we're learning a lot about the single genes that we know about in epilepsy. It can help us target therapy, and it also helps us understand why it is related with so many comorbidities, and hopefully gives us avenues of preventing those comorbidities as well as managing them. It's very genetics in epilepsy is very important for accurate reproductive counseling. A young family who has a child with epilepsy, deciding whether, about the next child, and that's an area where if you actually find a specific gene, it's vastly helpful. And it also makes us rethink how to manage epilepsy. The monogenic epilepsies, where you have one gene that's not a variant, that is pathogenic and not common. But what you know from genome-wide association studies, meaning they've looked at the whole genome, lots of people, huge number of people with epilepsy have shown that there are many relatively rare variants which increase your risk for epilepsy. They don't cause the epilepsy. And how does that help us manage or improve outcomes? Is a lot of the time we still don't know, but we're learning more and more each year. And most people with epilepsy, the etiology is polygenic. It's the combination of different genes that is causing that particular profile in that particular person. And it is highly heterogeneous. Now, next generation sequencing you'll hear a lot of when you talk about genes and epilepsy. When should it be considered clinically? We're moving towards thinking if you have a problem, you should look at genes in almost every condition now, but not also because to understand the problem better and maybe improve treatment options that are available. Now, and however, when you look at the genes, there are lots of genes, and you get a vast amount of data, and sometimes it's quite difficult to interpret, and sometimes you have to relook at it over time, because sometimes you may find a variant in a copy number variant, which right now is uncertain significance. We don't know what it means, and you say it's not related to the epilepsy. But then, over time, somebody from somewhere else is saying, I have this person with but with the variant of uncertain significance. Then someone else from some other part of the world says, I have. So unless we all pool our data, we are not going to know that actually very rare variant is significant. And therefore, I think that we all have to think again and think that we have to look at the genes. They may or may not be helpful in everyday management, but in the longer term, it is important for us to look at genes in epilepsy. Now, Sanger sequencing was the first type of test that used to be done, and it's very slow. It's a tedious process when you're looking at the genes by Sanger sequencing. And it said that if you had to look at the entire genome, it would take 60 years for one person to look at it. So it's okay for targeted things, and it's not okay, but it's useful, but it takes a lot of time. And then the next generation sequencing has come, where, which is, we use that. You can do whole genome sequencing and whole exome sequencing. These are not still mainstream. They're mostly as big centers or research trials, or you have to come into certain pathway to get it done. But most people, or most centers now have targeted gene panels. So you have, like we in WA have a targeted epilepsy gene panel, which has lots and hundreds of genes on it that we look at. And that's Pathwest Diagnostics runs the panel. But there are also private companies that provide it, sometimes come and go. But I think it's important for us to develop our own service so that it's stable, steady, and reliable. There's also third generation sequencing, which is improving, getting better and better. And it would be more accurate and faster when we have it up and running in clinical practice. I'm going to go back to the neonates, where you see the genetic etiology is one of the etiologies that we... Okay, I won't try, just take time. Okay, the third one on your left, the genetic etiology that we, but if you look at all causes of seizures in the neonates, hypoxic ischemic encephalopathy, the middle one, is the most frequent cause. And the genetic causes and metabolic causes because of genes together constitute about 10 to 15% of babies who have seizures. Why I'm saying it now, we say they are separate things, but they're not, and we'll come to that again. In neonates, you can get babies, and through childhood, you get what we call the self-limited epilepsies, or the medically responsive epilepsies. These children do well. They outgrow majority outgrow the seizures, and cognitively, majority do extremely well, like anyone else who doesn't have epilepsy. And the self-limited neonatal epilepsy is a condition which has taught us a lot about genes and epilepsies. So the common genes are like KCNQ2, KCNQ3, they're potassium channel genes, and SCNTA, but there are lots of other genes that can do it. But what's very interesting is the same genes, the KCNQ2 or KCNQ3, in one baby causes a benign seizure disorder, but in another baby may cause a very severe seizure disorder with developmental and epileptic encephalopathy. And that's where a lot of work is being done to see why in this person it does this, but in that person it doesn't. And so also with the genes in epilepsies, if you look at straightforward single gene disorders or causes for epilepsy, the highest yield or the highest number where you do get a gene variant that would explain things is in the 3-month to 1-year age group, if your seizures start during that period. And then next is less than 3 months. Next is 1 to 3 years when your seizures start, and then after that, when you start having seizures. So early onset epilepsies are more likely to give you a cause, like a single gene mutation. Most other epilepsies, later onset epilepsies, are often polygenic and are complex genetics. One of the things about getting that is, though it's a small number, but genes might actually tell you this is what you need to do. For example, if you have a gene abnormality where your glucose, the amount that is transferred from your blood into your brain is affected, so that not enough is getting into the brain. Your blood sugar is fine, but your brain sugar is not. And so that one will but it best responds to a ketogenic diet. So very early you should start the ketogenic diet in that sort of a situation. You can have genes that cause abnormalities in your vitamins. Then you have to give that particular vitamin or vitamin like pyridoxine for that disorder, and nothing else will really work. And so these are small numbers, but if you find them for that particular baby or that particular person, it's extremely useful. And though things like Dravet syndrome mostly start in childhood, but because we didn't have gene tests, there are lots of adults who have some of these syndromes who haven't been identified to have them. And that's becoming So more and more adults are being diagnosed with Dravet syndrome, where previously we didn't know why they had the epilepsy in the first place. And so there can a whole lot of things where you have specific drugs. They're very rare and they're a small number, but important for us to be aware of them and test them. And the things that point you towards, is this likely to be one of those genes? For example, in babies, there are certain things on the EEG which tell you this is much more likely to be one of those monogenic 10 to 15% disorders than because of all the other hypoxic ischemic encephalopathy, etc. So you need to be cognizant of that, to think of that if that occurs. And so on this slide, what I'm trying to say is, again, the mutation in the same gene in one person may cause a very benign, simple, self-limiting epilepsy, but in another person may cause what we call a developmental and epileptic encephalopathy, where it affects seizures are difficult to control, EEG is going abnormal, development is affected. And okay, I might skip that. Just to illustrate how complex epilepsy can be, this is a baby who had seizures which started on the second day of life. And initially, the 1 or 2 times the parents reported seeing right-sided facial twitching. No one else saw it. Was in the ward in one of the hospitals. And then the next day, one nurse who was there saw the tail end of one. The third day, they became much more. By the 4th and 5th day, they were occurring very frequently. And over the next few weeks, there were lots of seizures, lots of medications, and they had an MRI, didn't show anything, looked for any metabolic disorder, didn't find anything. And this was an EEG. What the squiggly lines you see in blue are from the left side. The squiggly lines you see in red are from the right side. And what you can see, there's increased activity where there's higher amplitude lines. Those are the epileptiform activity, and in between, it's not continuous. So the EEG background, we would say, is not normal, and that there's a lot of epileptiform activity. Over time, in this baby, this is a 1-minute epoch. The first one you saw was 15 seconds. So this is the EEG over a minute. What you can see in the blue is left-sided, green is right-sided activity. So you can see in the middle that that's a seizure disorder there. You see it's in one side, it flips to the other side, and therefore these are what we call focal migratory seizures in neonates. And so there are lots of, though the syndrome is like you see certain things on the EEG, clinically you see certain things, the genes associated are quite a lot. So the most common gene is one that's called the KCNT1 gene, but you can have a whole lot of those other genes can occur with that particular syndrome. And that, again, is a difficult genetic epilepsy to treat. We still don't know, not many things work very well, but there are some studies in adults which have shown that quinidine may be helpful. In babies, it's not been even as helpful as in adults, and it's not helpful in everyone, and we still don't know in who it might be helpful and who it might not be helpful. And but interesting, the same mutation which causes this can also cause autosomal dominant nocturnal frontal lobe epilepsy that can start in childhood or in adults. It can cause other types of the developmental and epileptic encephalopathies. We know it increases in the potassium current, but all of these also, there's a lot of research being done to try and see what you can do to decrease that potassium current, the abnormal increase in potassium current that occurs. Now, if we look at when we talked about neonatal seizures again, so if you put them into boxes of babies who have acute seizures, that's the most common in that orange box. Most babies will stop having seizures in 48 to 72 hours after they start having seizures. But a small number, less than like 1 to 2%, will continue and will never stop. Maybe it's more than 1 to 2%, 5% will continue to have not. But some will stop, and then if you go to the yellow box, about somewhere between 15 to 25% of babies who have seizures won't have seizures for many months, and then will start having seizures again. And then there are these babies who have the self-limiting epilepsies, which stop by themselves most of the time, or in the long term, about 10 to 15% may have epilepsy, but most don't. And the developmental and epileptic encephalopathies, where it's very difficult to get on top of seizures, and you're trying different combinations, and development also is affected, not only because of the epilepsy, but because of the gene itself. Now, when you say, okay, why do these babies who have these acute, I can't get this mouse to move. Okay, acute symptomatic seizures, after the latent period of months, sometimes years, go and have post-neonatal epilepsy. People are working out why this occurs, if there's any way we can stop the process. Interestingly, there's a small study where they've looked at the genes of all the babies who had the seizures as neonates, and they find that in those who have the epilepsy afterwards, they stop and then have, there's a much higher number of what we call coding variants in the epilepsy gene panel. So genetics plays a part in why some get epilepsy afterwards and some don't. And this may apply to stroke as well. Like when you have seizures straight after a stroke, some stop and some continue to have in the longer term. And also with the epilepsy, you just don't have epilepsy. A lot of the time when you have the genetic, straightforward gene disorders, you get, they may be associated with brains that are formed differently, or movement disorders, or sleep problems, or autistic traits, and so it's a combination of things, often in the developmental and epileptic encephalopathies. This is a international guideline for treatment of seizures, which also says in babies, if you don't know why they're having seizures, you should give them sodium channel drugs like carbamazepine or phenytoin, because they may have gene mutations that will work with it. We are part of this big study. Now, if you look at focal epilepsies, where you start from one part, again, these are thought to be like genetic focal, or there's a strong genetic component to them. And so these are the ones we used to previously call Rolandic epilepsy or benign focal epilepsy of childhood. But now there are new names for it, but they're just the same syndromes. But most of the children will do very well long term, will outgrow the seizures and do well. They have a very strong, they also have typical seizure patterns and EEG patterns. This is an EEG of a child with one of those benign focal epilepsies called SELECT. So the left-sided leads are color-coded in blue, the right is in red, and you can see in the middle of that slide, there are those spiky things. So those are epileptiform discharges, and they're coming from the left central region and temporal region. In sleep, they increase quite a bit. And so that is a very characteristic feature of this kind of epilepsy syndrome. But if you look at the siblings of children who have this, who've not had seizures, quite a number will have this EEG pattern, but they never have seizures. So the EEG pattern seems to be what's transmitted as a genetic trait. Then something else happens in some people, or some other genetics is involved, that makes the seizures happen. So I just thought put it in there to sort of understand how complex this is. And we've known about this for a long time. We still don't have many single genes that cause it, but we know it runs in families. And you'll get a very strong family history. My father had it, my mother had it, my grandmother had it, and outgrew it here. And so, but some of them with the same may start off looking like that, but go on to have very difficult epilepsies, a small number. And that's where we still don't know, and they're called the epilepsy, ESES, or electrical status epilepticus in sleep, or Landau-Kleffner syndrome, and we're still understanding why and what the complex genetics are. A very small number of those with ESES may have single gene mutations. The majority we haven't found, are not found. If you look at generalized epilepsies, like the juvenile myoclonic epilepsy, childhood absence epilepsy, the same thing. About, we know there's a strong genetic component, a strong family history of epilepsies in other relatives, but single genes causing it, very few. We know they're associated. Okay, if you have this particular type of variant, the risk is higher, but it's not straightforward. And so, and most of these children do well. But there's a small group over here who will have a developmental and epileptic encephalopathy. And that's where I think in future, genetics is also going to play a big part in helping us understand why that occurs and is there any way we can influence that. And so when you think of genetic generalized epilepsies, these are, most of them again start in childhood. There are some which will start in adulthood, but and their childhood absence, juvenile myoclonic epilepsy often starts in the teenage years, and epilepsy with generalized tonic-clonic seizures can occur in childhood or in adults. But there's a group of epilepsies that are, again, where it's not so simple. There's a lot of other comorbidities. And when a child with childhood absence epilepsy starts, there's, even now, it's very hard to say, majority will do reasonably well. But the some who will have difficulty, we still can't pick. And so that's why you're careful when you're prognosticating, saying majority will do well, but you can't see who is definitely going. There are a few markers, but not everybody with that marker will actually not do well. So it is a fascinating area, and hopefully we learn more and helps us with management. Now, these are just all the, all the epilepsies which are thought to have a genetic component to it, but these are, they can start at almost any age. They are ones lower down especially. And I don't know if, they're rare ones like Rasmussen syndrome and Fires or Norse, which are Fires and Norse start off in a catastrophic fashion with lots of seizures. And again, there seems to be some genetic component, but most of the time we haven't been able to put our finger and say, this is why it occurs in a particular person. Now, moving on to how does it help with management, say Dravet syndrome, which is usually a mutation or a pathogenic genetic variation, which is what we should be saying in the sodium channel gene. We know that in the older child and adults, sodium channel drugs don't work well, and drugs like stiripentol and fenfluramine are particularly useful. And so it has helped with management. We know, we've talked about GLUT1 deficiency. That's the one where glucose does not cross the blood-brain barrier and go into the brain. Yeah, we know that GRIN2A mutations, which sometimes cause epilepsy and speech difficulties, they respond best to drugs that work on the excitatory system, the NMDA pathway. And so we know, like tuberous sclerosis, vicapatrin works very well for that. We know everolimus could be helpful for that. And so there are specific drugs that might be very helpful in particular easily identified genetic epilepsies. We know that surgery may be useful in focal cortical dysplasia and with more. However, we now are learning that not all focal cortical dysplasias, if you have some genes, then you don't do as well as if you don't have those genes. Inborn errors of metabolism, you might have to decide how to modify the diet or use a specific diet or avoid some things in your diet for that. This is just, if anyone's particularly interested, that paper talks about a lot of new things that across the world people are looking at with regards to genes, epilepsies, and treatments. We've talked about most of the things in there, but interestingly, again, if you have a sodium channel mutation in the neonatal period, you will often respond to a sodium channel drug. But sodium channel mutation in Dravet syndrome may make seizures worse in somebody with the Dravet syndrome. So it depends on whether the mutation causes a gain in function of what that gene does or a loss of function. And so you need one step more, not just what the gene variant is, but also what does it do. So for it to be useful in management. This is just, again, a stride for a lot of work being done in neonatal animal models, and they're showing the ones in blue are medications we already know about and we use. But the ones in pink are the ones that are being developed and the ones where trials are occurring. So there are quite a few trials, quite a few drugs in the developmental phase, not yet ready to come to clinical trials. Some are creeping into clinical trials now. So it is, understanding genes has helped. This is just another pictorial representation that in the single genes, we've got ion channel genes, genes that affect receptors in your synapses, genes that affect transporters that take things from one place to another, or synapse related, and genes that affect lots of other mechanisms. Now, epilepsy in pharmacogenomics, it might be helpful, we said, because some drugs may work better for some people. And also, how much of a drug you need may be different. Some people metabolize drugs quicker or slower, depending on your genetic profile. And in particular genes, it might be useful to find out those modifiers of your metabolism. Then tolerability. We know that if you have certain HLA haplotypes, your risk of having adverse drug reactions, like severe skin reactions, is much higher. So if you're a person of Chinese ancestry and you have the HLA B1502, you would not use carbamazepine. So, and whereas if you're Anglo-Saxon, then even if you have this, your risk of developing the drug toxicity is much lower. So it seems it's not just that particular haplotype, it's also lots of other genes and your genetic makeup that we still don't know about. And it may help understand individual variability in responses. Epilepsy surgery and genes, as we said, working if a person's epilepsy is suitable for resective surgery, takes a lot of time and effort. But what we are now realizing is that even if you have a cortical dysplasia, if you have some gene mutations, your chance of the surgery being free is less than 15%. So a lot of centers now sort of do it in everybody. Like even if you have a frank cortical dysplasia even if you're considering surgery, you get an epilepsy gene panel done. Whereas 10 years ago, we wouldn't think of it. So so we have to be careful. And these are some of the genes that we now know that don't, even if you have a dysplastic lesion, the outcomes with surgery are not good, even if everything else falls into place. Whereas in single cortical dysplasias, in tuberous sclerosis, you can identify where the seizures are coming from. Seizure-free outcomes long-term are about 50 to 70%. I think this becomes very important as well to keep in mind. Personalized medicine, precision medicine, a lot is said to it, and often it's said in the context of genes, but I think personalized medicine has to be the person with everything, not just the genes, because most genetics is complex and it's not straightforward, single gene variants that are affecting epilepsy. Also, your EEG helps, your MRI helps, your personality helps, and when you're choosing what medication for which person, you're also thinking, what is the age of the child? Is it a male or a female? Is the person skinny or is the person overweight? Has puberty finished or not? So is the person need a tablet or does the person need a liquid preparation? So all of that needs to come into play. And so personalized medicine needs to put everything there. Is the person, how important is not being sedated for the person? So you use all of that. And I think when we say personalized medicine, it should be individualized medicine. And we also, I think, health, we need to realize whatever we know or don't know, with what we know, we need good health systems to deliver good quality care. And we all need to be advocates for that. Now, I'm just going to give you, do you have a few minutes more?
Yes.
Yeah. Okay.
5 more minutes, is that enough?
Yeah, thank you. Yeah. Gene discoveries in just an Australian perspective about where we are. Again, this was a study that we took part in from the Children's Hospital. This was across almost all the children's hospitals with pediatric neurology departments in Australia. And we're looking into trying to understand the mechanisms and inheritance of seizure disorders. And we know that the greatest impact of single genes especially is on the early onset epilepsies, the developmental and epileptic encephalopathies. And so it occurs in 1 in 1,000 individuals. And we should be diagnosing 300 children each year with a DEE across Australia, like if we're doing it well. And they're genetically heterogeneous with more than 400 genes implicated. This is a few years ago, so there'll be more now. And they can be, most of the single gene mutations, the most common ones are often in that person, they just occur at that time. And then they're autosomal dominant, like they can get transmitted, but it's not familial in that it does not come from that, except in a very, very small number if there's mosaicism, where you have 95% of your cells are one type and 5% have a slightly different genome type as a parent. But okay, then it's autosomal recessive or X-linked recessive or mitochondrial inheritance, which could be maternal inheritance in some. Now, the government gave a lot of money for an Australian Genomic Health Alliance, so this was across Australia. And there was an epilepsy flagship, like some of the money came to epilepsy, looking at genes in epilepsy. And so what we looked at were about 103 children across Australia who had epilepsies that had started early, who had a chromosomal microarray, but not had an epilepsy gene panel, because at that stage, not all the centers had epilepsy gene panels easily available. And so what it found was that a genetic cause in children with developmental and epileptic encephalopathies was found in 40% of children. So it's not a small number. And 30% were, about 33% were straightforward genes. Then they had to do special tests going to exome sequencing, genome sequencing, looking at the parents before you came to a conclusion. And I think it was 2 or maybe 3 where they initially thought wasn't significant, but subsequent information from other places changed it from being uncertain significance to being significant variant. And so that's just saying the genetic etiology was identified in 41% of children with seizure onset under 2 years who had a developmental and epileptic encephalopathy. Now, we are in Pathways Genetics has been doing epilepsy gene profile. It was not funded through Medicare, but Pathways put some, and we've been working on it for more than 10 years. 50, and we've been doing it, but it's taken us a lot of time because of funding and shortage of staffing, etc. So each time we put a gene test, I'm sure some of you are aware, it takes a long time for us to get a result, which shouldn't be. Because time frame, it's essential to have a short turnover time for it to be really meaningful in management. So adequate funding of epilepsy and genetic services is very important and imperative that we all advocate for it. Okay, that's my conclusion slide. So we are thinking about WA, but this is a problem across the world where services are limited. And in some parts in the low-income countries, the situation is much more dire and worse, with some countries having just 2 medications available. So the global burden of epilepsy, this was many years ago, said 50 million, now it's more than 70 million. The WHO actually released what they call the Intersectoral Global Action Plan for Epilepsy. It's called the IGAP often, like people refer to it as the IGAP plan. And that is thought to be one of WHO's best things that it has done. It has only started in the last few years. And the IGAP focus is on improving quality of life through a person-centered approach. And that it has to be in the context of where, what, the economics of the place, etc. And the there was a campaign started by the ILA, the IB, the WHO. I think it was 1997 when it first started, calling it Epilepsy Out of the Shadows. And people are still working on it. And I think we all still need to work on it because though things are much better, the stigma is still there at times. And therefore, if anyone's interested, just Google IGAP. It's quite interesting and quite useful to read. And I'll conclude with saying adequate funding and resourcing is essential. So we have to work towards that. Thank you very much.